All right, now I think we're recording.
Yes.
Good. A couple things. One, if you haven't heard, the OTEP plan for 2025 has been approved by the state. We've got the first quarter scenarios done. The third quarter scenario is done. Working on the fourth. Alyssa Dashbach from Mummy's working on quarter two scenarios. Also, at the end of Noah's presentation, we have a brand new video by Dr. Weiche that we want to show you. It's about also kind of enhances what Noah's going to talk about today, about the stroke plan and protocol PeaceHealth, as well as some BLS assessment that Noah's going to talk about. All right. If you please just go ahead and mute yourselves. And of course, if you've got any questions, go ahead and put them in the chat. I'll monitor that for you, Noah. Noa Hardwick is the stroke program manager at St. Joe's Hospital. Noa can talk about her experience and everything else, but I sit on one of her committees. We meet every other month about stroke care at the hospital, and there's an EMS component to it, which Chief Russell and I have been part of since I've been here. And so that's it for me. Noa, why don't you go ahead and introduce yourself and take it away? And thank you for being
Thanks.
here.
Thanks for inviting me, Steve. Yeah, my name is Noa Hardwick. I am the stroke program manager here at St. Joe's. Been doing this full time since about March, but part time since probably 2020. Before that, I was a resource and float nurse for about 10 years, and before that, a surgical nurse, and before that, a jail nurse. So um, that is my background. But going to be talking to you about stroke today, both from an EMS perspective as well as our process here at St. Joe's. We are a Department of Health Level 2 stroke center. So our objectives, take a little look through here, stroke statistics, chain of survival, the BFAST exam, EMS triage, last known well time, recognizing different types of strokes, transport and ED triage and imaging and ED process. Statistically, 96% of Americans live within 60 minutes of an emergency department that has acute stroke care, but only 1 in 4 people experiencing stroke symptoms seek emergency treatment. Stroke is the leading cause of disability in the US and the second cause of death worldwide. 80% of strokes are preventable. They have preventable risk factors through lifestyle modifications. Things like smoking, activity, diet play a big role in stroke. So to begin, stroke chain of survival, bunch of D's here: detection, the recognition of symptoms, dispatch, immediate activation of 911, delivery, pre-hospital notification and transport to that is a primary stroke center or comprehensive stroke center. We are a primary stroke center. Basically what that means is we do not perform clot retrieval or thrombectomy here. We send those patients off to Harborview. Door time, door immediate ED triage, imaging, labs for data, decision for diagnosis and treatment, drugs, appropriate therapy for the patient depending on what's going on with them, and disposition, admission to a stroke unit or a transfer. So we're going to start with the first 3 here: detection, dispatch, delivery. The exam that you guys use is the BFAST. So I'm going to discuss a little bit more about those individual items. So BFAST exam, balance, loss of balance, headache or dizziness. Eyes is for E, blurred vision. Face is F. One side of the face drooping. Usually find that when smiling. Arms, arm or leg weakness. Speech difficulty for S. And T is time. Time to call and time to get to the ER. So balance. Does this patient have balance or coordination problems? Is this normal for them? Did they have balance problems before? Were they able to walk with an even gait before these symptoms occurred, or is that unusual? Do they stumble when they walk? Do they lean to one side if they're sitting in a chair? If they're a person who's unable to walk, are they kind of leaning over and, looking a little uncentered? Eyes. You can have a patient look at a picture and ask them what they see in the picture. Do they see only half of the picture? Is there some double vision? Are there parts of it that uh, they're unable to see? Is their vision blurred? Have they lost any part of their visual field? Recently had a patient who had a posterior stroke, which is what usually affects patient vision. And when he was talking about most of his symptoms, it kind of resolved in ER, but he was looking across the room at a light switch. And with a fixed gaze, he was saying that the bottom right of the light switch, he couldn't see it at all. It was just like a blank spot. So sometimes with posterior strokes, the only symptom is going to be vision. You can see in these pictures here, the primary visual cortex, the bottom, this red and green, that is where the back of your head, back of your brain, where these strokes occur. And there are different types of vision loss that can occur depending on where the clot is. It could just be the right eye, like this right monocular blindness. Bitemporal hemianopsia would be kind of like a tunnel vision. The outsides of their vision are essentially gone. Left homonymous hemianopsia. There's right, left, any real combination depending, but it would just be the left side of each visual field. This one in the middle here, this is binasal hemianopsia. You can't see the center of your vision, only the outsides. So various ways that can present. Face is generally really straightforward. Ask the patient to smile, ask them to show their teeth. Is one half of their face drooping? Are they uneven? This gal right here is called ptosis, where her one eye is drooping. Arms, ask the patients to extend both their arms straight in front of them. Does one arm drift down? Do they have any difficulty lifting an arm? Are they able to lift their arm at all? Something that happens a lot too, that's going to be a little more subtle. Do they report clumsiness or weakness in just a hand? Sometimes people feel like their coordination is off. That can be a symptom. Speech. Have them repeat a simple sentence. Have them say something like, Mary had a little lamb. A positive sign of stroke would be an inability to speak, of course, though that's not specific to stroke. But garbled or slurred speech, words that make no sense, or inability to find words, inability to understand your words, are all positive signs, especially when combined with lateral one-sided symptoms. And of course, time. If any of these BFAST criteria are positive, they may be having a stroke and they need to go to the ER. So initial stroke triage. So you've got a patient who's showing symptoms. So this is EMS from on scene to en route to the hospital. Of course, your normal assessments that you guys do for everyone. These patients should always have their airway, breathing, circulation confirmed. As far as this is kind of more of an ALS, but 2 large bore IVs, 18 gauge or above the wrist for contrast, CT contrast. And disability, if the patient is found down, of course, immobilizing their C-spine, assessing their level of consciousness. So at this point, we've done a BFAST, we have a suspected stroke. En route, really, really big deal is pre-hospital notification. That smooths the way for us, makes things go a lot more quickly. Registration's notified, a whole host of people are notified ahead of time. So letting us know as soon as possible is extremely helpful. Obtain a blood glucose, and as you are able to, treating over or if under 70. Getting a set of vitals. There are treatment things that we can't do if the blood pressure is super high. So letting us know that ahead of time is also really, really great. If ALS, treating systolic that is over 220, keeping oxygen at or equal to 95%, or above or equal to 95%. EKG helps us know, for example, like if this patient is in AFib, the ER doc can take a look at that. And then most importantly, what is the last known well time? What time was the patient for sure last seen to be at their baseline last well? So the importance of a couple things. Importance of blood glucose. The reason why this one's important is because hypoglycemia can mimic acute stroke symptoms. Stroke symptoms that have been reported due to hypoglycemia or stroke mimic symptoms include one-sided weakness, speech difficulties, and vision loss. These things have all been reported with just really low blood sugar, particularly in diabetics. Hyperglycemia is also good for us to know, again, particularly in diabetics, because it can predict or let us, I don't know, I guess it can be a predictor of a larger stroke, poor clinical outcome, higher risk of mortality, people with really high blood sugar. Generally, there are a lot of comorbidities that go along with diabetes, as we all know. So the importance of the last known well. Last known well time is the most important thing that you can discover for us because it guides treatment. What is the difference between the time of last known well and the time of symptom onset? So these aren't always the same, and it's a really important distinction to make. This is something that we come up across and report in the ED a lot. So it's a really good thing to know the difference between last known well and symptom onset. So last known well time, this is the time that patient was last known to be without signs and symptoms of the current stroke or their prior baseline. Symptom onset is when symptoms are first noticed by a witness or by the patient, depending on, the patient's credibility and reliability. When the onset of symptoms is clearly witnessed, then the last known well time is in this situation, it would be identical to the time of symptom onset. Though sometimes symptoms began before they were noticed by either the patient or a witness. For example, patient was found down at 11:30, that would not be an accurate last known well necessarily. Yeah, that's just when they were found. So say in that situation, they were found down at 11:30, but their spouse or a neighbor came by to have coffee at like 10 a.m. So 10 a.m. would then be the last known well time. The patient isn't always a reliable historian. They're not a reliable source for last known well because they may not notice their symptoms at all. Part of having stroke sometimes is that a patient doesn't even realize they're having one. So let's see. For an example, patients with one-sided neglect don't realize they're neglecting half their body. Sometimes people who lose half their vision field don't realize that part of their vision is gone. So that's the difference between last known well and symptom onset. Basically, we want to make sure we know when they were definitely at their last normal. Recognizing stroke symptoms. Let's see. So for this is just some cerebral vasculature and the distribution of what the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery, where they supply, where those arteries supply. So the MCA, middle cerebral artery, controls face, arms, speech, neglect. Anterior cerebral artery, let's see, it branches off the internal carotid artery and supplies the anterior medial portions of frontal and parietal lobes. It is generally least commonly affected by strokes. Classic signs of an ACA stroke would be like leg weakness, sensory loss. So in these situations, being sure to evaluate lower extremity strength and sensation, as part of your FAST exam. That's part of why that's important. Sometimes behavioral abnormalities, incontinence can occur in these strokes. Let's see. Generally, the larger strokes you see are going to be a lot of middle cerebral artery strokes. Going into the middle cerebral artery stroke that affects right side of the body. When it's occurring on the left side, that'll give you right-sided weakness, right-sided sensory loss, right visual field cuts, right homonymous hemianopsia, same side of visual field affected in both eyes, left gaze deviation. The eyes are going to look to the left, to the side of the stroke. Dysarthria, which is basically muscle control, difficulty speaking because of muscle control issues in the mouth, difficulty reading, difficulty writing, calculating math problems, or just complete inability to speak. Right middle cerebral artery strokes, which affect the left side of the body. Again, it's the opposite kind of left-sided weakness, sensory loss, field cut, visual problems. As part of this too, right middle cerebral artery strokes can cause anosognosia, which is when the patient is not aware that they're having a stroke. They're not aware anything is wrong at all. Again, when they're a poor historian, it is often because they have a right MCA stroke, dysarthria, inattention and neglect, part of not knowing that something's wrong. Posterior stroke, these ones can be a little more confusing because they're often not one side or the other. They're not really lateralizing. These can cause, but they can be incredibly disabling, which is why they're important to know about. They can cause motor and sensory loss in all 4 limbs, cross signs, cross sensory findings, meaning they can have stroke-like symptoms on both sides, kind of confounding the exam. Limb and gait ataxia, so that's just muscle control issues. Ptosis, that's eyelids that are droopy. Dysconjugate gaze, eyes that move independently from one another. This can be caused by a posterior stroke. Increased tone with posturing on both sides. That picture in the middle there shows decorticate and decerebrate posturing. Posterior strokes can cause that. Usually that is a pretty bad sign when you have posturing. Nystagmus, which is rapid and controllable eye movements. Again, dysarthria dysphagia, that's difficulty speaking, difficulty swallowing, locked-in syndrome, where a patient essentially understands and is aware, but they're unable to respond or even move. Amnesia, really bad vertigo, dizziness, nausea, and vomiting. Perioral paresthesias, basically that's numbness and tingling around your mouth. And bilateral visual field defects. Again, these ones can be really disabling and a little bit more confusing because they don't show one side or the other. So we have 2 types of stroke, ischemic and hemorrhagic. Hemorrhagic gets forgotten quite a bit because people don't often think of it as a stroke, but it causes the same symptoms. So, and it also only makes up 13% of all strokes, approximately. So ischemic, of course, an abrupt blockage of arteries that lead to or in the brain by an embolus or a thrombus. Basically, an embolus being blood clot and a thrombus being, it could often be, say, plaque that breaks off. And then hemorrhagic stroke, bleeding into the brain tissue when a blood vessel bursts, including intracranial hemorrhage and subarachnoid hemorrhage. So basically, if someone were to have a traumatic head bleed, that's not considered a stroke. But when we have a spontaneous one, like an aneurysm that bursts, that kind of thing, that would be considered. Sometimes because people have really high blood pressure, that can cause a hemorrhagic stroke. So basically, non-contrast head CT is our gold standard for identifying blood in the brain. And that's something that happens as soon as you guys bring them into the ED. And for that, we don't actually need IVs. So hemorrhagic stroke, same symptoms as an ischemic stroke. All of the distributions in the brain, depending on where it's at, they're going to cause the same things. Some exceptions include oftentimes a hemorrhagic stroke is going to be preceded by what the patient reports as a sudden severe headache, worst headache of my life, thunderclap headaches. Sometimes they do hear a really loud noise preceding this, like a thunderclap. Oftentimes they can have nausea and vomiting with these kinds of strokes, more often generally than in ischemic strokes. Rapidly decreasing level of consciousness, that's due to the pressure of that blood on the brain, and often inflammation and seizures. Important thing to ask, are they on an anticoagulant? Are they on warfarin, any kind of heparin-based medications? Aspirin even is good to know. TIA versus stroke. Transient ischemic attack, TIA, is a temporary blockage of blood flow in the brain. Clot usually dissolves on its own or it gets dislodged somehow. Maybe it's a little bit smaller and symptoms may last from a few minutes up to 24 hours. And while a TIA doesn't cause permanent damage, it's a warning stroke that can signal possible full stroke. So there's also no way to tell if stroke symptoms will lead to a TIA versus a stroke. So a lot of times, if you have a patient that has stroke symptoms and you'll start to notice in the rig that their symptoms are resolving, definitely still want to see them here, but probably going to end up being a TIA. Sometimes they resolve in the ED, sometimes they resolve in observation here. But transient stroke symptoms still need emergency assessment. Nearly 1 in 5 people who have a TIA will have a stroke within 90 days. And 2 in 5 will learn that they actually did have a stroke instead of a TIA. And TIA can mimic other conditions, so it's best to be evaluated in the ER. Maybe they're having something else that's an emergent condition. And because these people, have such a higher likelihood of having a stroke when they come in to see us, even if symptoms do resolve, we can put them on treatment plans that will prevent them from having a stroke. And find out where that might be coming from. Maybe they've got AFib or something. Activating a stroke code. So basically, your pre-hospital notification is so helpful to us because what happens when you call us is we immediately page out to this whole team of people: CT tech, ED physician, our neurologist, registration, EKG, lab, pharmacy. Depending on if it's after hours, we notify UW in case this patient might need transport. In addition to this, it also goes to our house manager, a stat nurse, resource nurse. So there's a bunch of people that are mobilized when we get pre-hospital notification. All patients with symptom onset in the past 24 hours do need to be seen. And we really appreciate it when you can advise charge of last known well ahead of time. Again, it helps guide treatment. ED triage and treatment decisions. So by the time, you hand off to us and we get report from you, we're going into our door immediate ED triage, imaging labs, decision drug portion of our chain of survival here. This is our stroke algorithm. This is what happens after you guys bring us a stroke patient. We've got sort of 3 different pathways that we follow. Just to kind of give you the quick and dirty, the code stroke pathway. Those are our patients who have a last known well within past 4.5 hours. They go stat to CT, get their labs, and possibly get clot buster medication. We use tenecteplase if certain criteria is met. And they could also, in addition to tenecteplase, go down to Harborview if there's a large vessel clot. Those ones are pretty straightforward. Generally, you guys are bringing those people in pretty quickly. I don't want to speak to it, but from my understanding, those people are often kind of code red types. Our middle arm here is stroke standby. This is kind of a newer process for us. These are for patients who have a last known well time within 4.5 to 24 hours. By the time they're seen by an ED physician, we get a NIHSS score, and if they are over or equal to 6, there's possible treatment that they could still qualify for. So what happens is they still go stat to CT and CTA, still get their labs. If they do have a large vessel clot found on imaging, they get a neurology consult or telestroke consult and go down to Harborview possibly. If there is no large vessel clot, then again, they do get a neurology consult or telestroke of after hours. And if they're a patient who say they woke up with stroke symptoms or they have an unknown last known well time, one of our newer protocols here is we evaluate them as a wake up TNK candidate. This is a newer process, and we're pretty excited about it because what this means is that these patients who prior to now would have had no options for treatment, they would have just had to live the rest of their lives fairly disabled. Now they have options for treatment, and it's going pretty well. We went live with this earlier in November. On the right side here, we have typically these are our observation patients. There's not a lot of intervention that we can do if they're a person who has a last known well of over 24 hours ago or a lower NIH score or stroke scale score. Generally, we admit them for workup or observation. So as far as EMS role with this code stroke, those are patients, again, within 4.5 hours of last known well, be positive BFAST symptoms in the field. They could have TNK, the clotbuster medication, and or thrombectomy. Our stroke standby patients, these patients either can get TNK or a thrombectomy, never both. People who are within 4.5, or not within, who are between 4.5 hours to 24 hours past their last unwell. These patients you would be transporting to the ED for a large vessel clot rule out. BLS transport is acceptable. Don't need to come code red necessarily unless traffic would cause a significant delay. Door in, door out goal. So basically from the time these patients come to us to the time we pack them up and send them to Harborview these are for our large vessel clot people is 90 minutes or less. That's for our stroke standby. And for our wake up TNK protocol, these patients have a potential for TNK or observation only, and they do require MRI. So these are patients who have a wake up stroke, who woke up with stroke symptoms, or they have an unknown time of last known well. Again, need to come to the ED. BLS is fine, only unless traffic would cause a big delay. For these people, it's really important to obtain their next of kin contact information. Generally speaking, with stroke patients, it's always really helpful if you can get a next of kin information for us, or if they're at a SNF, extended care facility, if you can get information of the person who was last taking care of the patient. Super helpful. So we often contact them. And our door to needle goal for all of these patients that do get to next of place is 60 minutes or less. So non-contrast head CT, just to kind of give you an idea. These are images showing what we see. That white part, that is blood in the brain. This is showing what a head bleed would look like. You can see on our head bleeds, they kind of flow into that empty space in the center. We do CTA with rapid AI. So we have an artificial intelligence system that can tell us whether or not we might have a large vessel clot. You can see on our CTA here, this is without the AI. The contrast is basically lighting up the vessels, and on the right here, it's clearly not symmetrical. There's something going on there. When you have AI, it actually tells you suspected LVO and gives you a little bit better detailed view of the vasculature. So it's kind of a cool feature that we got. So thrombolysis, the breakdown of blood clots formed in blood vessels using medication. We, again, this says TPA, but we use TNK. Shows you normal blood flow blocked by a clot. And TNK dissolves that blood clot so we can restore blood flow. We used to use TPA that required both a bag that you had to hang in addition to an IV push. TNK is kind of cool. It's an IV push only. And there's a lot of studies saying that it has a faster recovery for our patients and sometimes a better long-term recovery, though there are still risks involved. So LVO, large vessel occlusion, just showing you, since this is kind of really the only field tool, you guys don't do the CSTAT, but this is sort of the only field tool for EMS to determine potential LVO in the field. It's gaze, arm weakness, and level of consciousness. And they assign points to it. For a gaze condition where both eyes move differently to each other, arm weakness, can they or can they not hold up their arms for 10 seconds equally to one another? And then level of consciousness. They answer level of consciousness questions like, what is today's date? How old are you? That kind of thing. And positive CSTAT is defined as a score of over or equal to 2. This is CT perfusion with rapid AI. Another cool tool that we use here. Basically, it shows a mismatch map. The pink represents reduction in cerebral blood flow, and green is areas of poor perfusion, poor brain perfusion. When there is a mismatch between basically the infarcted or damaged core and the ischemic penumbra. And the ischemic penumbra is essentially the area of the brain that could be reperfused if TNK were given. So like say a mismatch volume of 15 milliliters or a ratio of 1.8, which is what the AI would tell us. This indicates thrombectomy could reverse some functional damage. And this is in the case, of course, of a clot. If the patient does go to UW for mechanical thrombectomy, they could be going to get an aspiration and clot extraction. There are also clot retrieval devices, which are pretty cool. There are a few different ways that they do this. And this shows you both the clot that was retrieved as well as before and after of blood flow. And sometimes these are very successful. Pretty cool to watch. Intervention time goals. Our door to CT time goal here is 10 minutes or less. So from the time you guys drop them off to the time we get them into CT, hopefully we're doing that in 10 minutes. 5 minutes is better. Door to needle time, 60 minutes or less, golden hour. Door in, door out from the time you guys bring them to us to the time we send to Harborview, 90 minutes or less. So during a stroke, 32,000 neurons die per second. This kind of just shows when things go well. Patient has stroke symptoms, 911 dispatches EMS. EMS assesses, activates code stroke, some pre-hospital notification. The ED accepts the patient, registration comes by. Patient arrives met by the stroke team, doctor reviews, and CT, CTA is done. IV thrombolytics are started. Airlift Northwest usually takes them down to Harborview if it's a large vessel occlusion. And we've got a patient who can walk and talk and still hang out at the park. If this breaks down really at any point in time, we've got poor communication inefficiencies, travel delays, these kind of things, then we've got a patient who ends up in the ICU and has long-term disability. So giving a time frame too, from where we're kind of looking at as far as from the time the patient notices or from the time the stroke symptoms start to the time they go to Harborview if they've got a clot. Any questions? That's all I got for you.
I have a question for you, Noah.
Yeah.
How is the new stroke protocol working in the hospital? Are you meeting I know it just started less than a month ago, but
Yeah.
have you reviewed it?
We began on November 4th officially.
Oh,
And yeah, we've had I think 3 patients come through as far as like wake up strokes and go through MRI. So far, we haven't had a candidate for TNK yet. We had one that was very close, and then they started to, their symptoms started to resolve, and their NIH dropped under the limit of 6. Um, but so far, so good. It's been going smoothly. Just some questions here and there, clarifications, but otherwise going well. And I do plan to put a couple of the case studies from these patients into our quality meeting next week. Kind of look at them a little closer.
And I have one more question about
Mhm.
the large vessel occlusion scale, and it's
Yeah.
using in Cincinnati. How'd you pick that one versus the van scale? And if you're not familiar with the van scale, I know we used it in the system I came from, and it worked pretty well. So I was just curious how you picked the Cincinnati scale. I mean, they're all similar, but I understand the van
Sure.
scale also has a pretty good, I guess, more than the, I guess, what am I trying to say? Higher accuracy than the NIHSS scale.
Good question. Basically, just because that is what they use in Seattle and uh, also with our larger system hospital, Riverbend, in Oregon. That's the CSTAT is what they're using. And as far as EMS goes, we don't, as correct me if I'm wrong, but we don't use either of those here in Whatcom County. Yeah. Okay.
No, we kind of mentioned it a couple of times to the MPD, and but just I know it hasn't come. I don't think it's come up in Medic CME at all as well,
Okay.
but I could be wrong. I know there's a couple paramedics on right now that might be able to answer that or not, but I don't know.
Okay.
I was just curious.
No, good question.
The reason
Just
why,
as an example. That's the
yeah,
only reason I brought it in.
well, I'm also a little biased because when we were trained on it, I was the first medic in our system to use it. So
Oh, cool.
yeah, I was just happened to be lucky.
I mean, I am super supportive if you guys do introduce either one of those. And I would love to know about it if that ever does happen so that I can integrate
Oh yeah,
that
yeah,
into our ER teaching.
right. Anybody else have any other questions they want to ask Noah? I don't see anything in the chat. Uh, but yeah, okay. Well, Noah, I appreciate it. Thank you very much. A couple things that I want to add is one is the PeaceHealth update. At one of the education committee meetings, they wanted a handout. So that handout is in the training officer's hands as well as it's on Rescue Hub. It's also in Hand Heavy as well as in the PPP app. The addendum is where you're going to find that. And on the other document that people wanted into the protocols were the PeaceHealth trauma criteria, and that also is in Hand Heavy and PPP. We are working on the protocols as we speak. We hopefully going to meet with the MPD, both Dr. Wayne and then the incoming MPD, Dr. Weiche, hopefully next month. We're just trying to figure out dates and everything. We've got a whole bunch of questions. The protocol committee is working really hard to on the new set of protocols. It'll be hopefully out in the spring. That's the plan right now. Uh, so I'm trying to think if there's any other questions. All right. Well, I want to, for those who don't know, Dr. Emily Welch is going to be one of our physicians in the system, and Emily's going to say hi, but Emily's going to be concentrating on CQI and BLS training as well as BLS component as well. So, hi, Emily. Welcome.
Hi, thanks for having me. Sure to, sit in on your training. It was nice to be here, but I thought I'd say hello real quick and thanks Steve for giving me just a second. But I'm currently down in Houston for a wedding, so that's why it's sunny here all of a sudden. But it's nice to meet you all. I think I've met at least one or two of you previously, but I hope to get to know all of you. I'm already onboarded as an ER doc at St. Joe's, so if you guys see me, feel free to say hello and come tell me about, how your day's going and everything and how I can be of use. I'm coming on as a supervising physician for Whatcom County. So starting first of the year, you'll see me around. Hopefully I can, help you guys with anything you might need and, make your jobs and your lives a little easier as we go. So let me know, come say hi. It's nice to meet you all.
Thanks, Emily. Good to see you. Enjoy the
See you
sun.
Thanks.
Yeah. All right. So I got about I think it's about 7 minutes and 45-second video. It actually kind of recaps what Noah says. But Dr. Weiche wanted to create one. We're in the final stages of editing, so this is the first showing of it. So if you just hang in there and let us know what you think as well. I'm going to share my screen in a second. There we go, share, and let's see if I can get everything to work.
Hi, I'm Dr. Ralph Weiche, and it's the end of 2024, and I wanted to give you an update on our stroke protocols at the hospital. So recently, the hospital has standardized their stroke protocols into 3 different categories, and I want to talk about what those categories are. The first one is the acute stroke patients, and nothing has changed with that category. Those are our patients who are eligible for thrombolysis if we can get him here and be evaluated and get thrombolytics within 4.5 hours of symptom onset. So those are probably our most time critical patients that we take care of, where they are literally losing millions of neurons every minute. So those patients will come in code red, and the procedure for that has not changed. There's 2 new categories that I'll talk about. One is a stroke standby, and those are the ones who have had symptoms within 24 hours. And the other one is a wake-up stroke that I'll talk about. So one of the most important elements in any of the stroke algorithms is to know when the last known well time is. And so the last known well time is the time when they were last normal or at their baseline. When you are assessing a patient, it'll be imperative that you get the last known well time. And when you call the NTL, you let them know when the last known well time is. And before you leave the scene, I want you to get the name and the number who gave you that time, because we are going to call and confirm that last known well time. Studies have shown that 58% of the time, medics get the last known well time wrong. And in reality, the time that they were last known well was earlier than what they say, which means that the patient would have inappropriately got thrombolysis, placing them at risk for intracranial hemorrhage. So the first category is the code strokes, and nothing is their code strokes. So the code stroke are the ones who are eligible for getting thrombolysis within 4.5 hours of their stroke. Of all the things we do, treating a stroke is probably the most time critical thing we do, as millions of neurons are lost every minute. So if you have a code stroke, we want you to come code red. You'll be greeted at the door, and the patient will be assessed right outside the door, and we'll decide whether we want to continue with the code stroke. And they'll immediately go down to the CT and get a CT and a CTA and be evaluated as whether they're a candidate for thrombolysis. So the stroke standby is any patient who develops symptoms within 24 hours. So if you have a patient who has a positive BFAST exam and you believe that they had a stroke with their last known well time within 24 hours, then those patients will now come in as a stroke standby. And this is a new protocol for us. So if you have a patient within 24 hours, you want to, and you call in, you let the NTL know that, and you will be greeted at the door just as you do with the acute stroke, and they will go directly down to the CT scanner and get their CT and CTA. What we're looking for in those patients is to see if they have a large vessel occlusion. If they have a large vessel occlusion, then those patients are candidate for thrombolysis, and they will be transferred down to Harborview for thrombolysis. The goal is for that to happen door in, door out in less than 90 minutes. Those patients don't have to be transported code red unless the traffic is such that it's going to slow you down for multiple minutes, then code red might be appropriate. Otherwise, they don't need to come code red. If they're being transported by ALS, I would like you to place a 20 or an 18 gauge IV in the right AC for their CT. Whether they're BLS or ALS, if you have time, I want you to get a rhythm strip or an EKG to find out if they're in atrial fibrillation. That will help us assess their risk of whether they actually had a stroke or not. But the IV and the rhythm strip should not delay their transport. They should still get here as expeditiously as possible. So the third category of patients are the wake-up stroke patients. So these are the patients who went to bed and they woke up with symptoms. Technically, the last known well time would be when they first went to bed, but you don't know, did the stroke happen 8 hours ago or did it happen 30 minutes ago? We can tell based on an MRI scan whether they potentially had their stroke within the 4.5-hour window for consideration for thrombolytics. So in the wake-up stroke patient, where somebody woke up with stroke symptoms and their last known well time was when they went to bed, we would consider those patients in this category of wake-up stroke. So for those patients, what we're looking for is whether they will be candidates for thrombolysis within that 4.5-hour window. So if you have a wake-up stroke, when you call to give report, let them know that you have a wake-up stroke. What will happen in that case will be just like with the other ones. They'll show up at the door. We'll get rapidly assessed to decide whether we're going to continue with the stroke protocol, and they will go down to the CT scanner and get a CT and a CTA. If they have a large vessel occlusion, they'll be transferred down to Harborview and they'll get thrombolysis. If they don't have a large vessel occlusion, then we can do an MRI scan, and that will serve as a proxy for telling us whether they are within the 4.5-hour window for thrombolysis. So we can tell by looking at the diffusion weighted image and a T2 image on their MRI scanner whether this stroke was acute. If it was acute, then they would be a candidate for thrombolysis and they would get TNK here at the hospital. So those patients also need to be transported emergently so that we can have them assessed within that 4.5-hour windows. The challenge is going to be that these patients need an MRI, and an MRI takes much longer to get, and the studies often take 2 hours for the type of studies we do, which means we'll have to take the current patient out of the scanner, put our patient in the scanner, and the imaging takes a while. So it's even more imperative that we try to assess these people as quickly as possible to try to get them within the window. If you have any questions about whether your patient might fit into one of these categories, you, of course, can always call either the STAR doc or the NTL, and they will help guide you as to whether they feel like these patients, your patient, is a potential candidate for one of these interventions. I hope that answers your questions, and you are updated as of the end of 2024, and we will continue to keep you updated. Thank you very much for what you do. Weiche, and it's the end of 2024, and I wanted to give you an update.
All right, there you have it. I get some more edits to do. I've watched it numerous times, did some other things, and we'll try to get some of those things straightened out. I don't know. Eventually, the video will be out on our YouTube channel and also on Rescue Hub, and also go to the training officers once we get the final product done. If you've never done some editing and videoing and all that, it takes a little bit of time as well, but we're working on it. Well, I appreciate everybody being here. Have a good Thanksgiving, and looks like we'll probably do the next BLS focus training probably in 2025, sometime either in late January, early February. Emily and I are going to work on some topics, but if you got a topic, let me know. So thanks, everybody. Have a great day and have a happy Thanksgiving.